This is Dr. Paul Grundy. I'm the founding president of the Primary Care Collaborative, and I'm currently with Innovaser. It's a pleasure to be with you here on the International Day of the Nurse and the Midwife. And we're going to talk a bit today about the transition that's occurring around the world and how healthcare is delivered. And the first thing I would like to talk to you about is the basis of the foundation of delivery from where I learned it so many years ago in medical school. The model is known as the Flexner model. It comes out of Germany and was adopted in a report in 1911 in the United States. And that's where they look at medical students or potential medical students for how much they can store in their brain. And then that medical student completes, in essence, a terminal degree. In the United States, it's 8 years, and in England and in many other parts of the world, it's 6 to 8 years of training. That model is known really as a master builder model. We're the last profession where the data storage device is our brain. Now, that model of care, or that model of doing things, we think of perhaps with building cathedrals in the Middle Ages, where it was a master builder who stored information in their head. And that model has failed us. Why? Because there's too much to store in one person's head, by far. And we still select and choose who becomes physicians by exams and by an understanding of literally how much they can store in their head. So this particular diagram depicts the sort of role of the master builder model. And what we've moved to and what we're moving to is a model of care in which the center of that universe is no longer the doctor's brain. The center of that universe is the patient. And the concept is one in which we move away from the data storage device being a physician's brain, as we have in most other industries. So we no longer build skyscrapers with a master builder like we used to build a cathedral. We have a plan. We have data. We have a team of folks who have a function in delivering the building of that skyscraper. And that's the model we're moving to now in healthcare. That model is sort of taking hold in many parts of the world, but it's really a team of folks who provide care. You see, we really have to have much more than one human being's data storage device to impact the complexity of healthcare as it is now. There were only a few treatments for diabetes when I graduated from medical school back in the 70s. Now there are thousands, right? I mean, and the problem has been really around the way we get at supporting data in this new world with that degree of complexity. We have not, in the healthcare industry, responded well to programming a computer and as we would launching a rocket to the moon and back. And the reason for that, I think, is because it's, a gazillion times more complicated to manage 100 diabetics with 100 personalities than it is to launch a rocket and understand the atmospheric physics, right? I mean, it's just a degree of complexity. So I like to say this is well beyond rocket science. But in this new world of data, in this new world of team-based care, we begin to think about what it is that the clinician should do. And when I say clinician, in many countries, the clinician could be a physician. It could be a nurse who's trained to be a practitioner, or a midwife, or a nurse anesthetist. It could be, as in the United States, somebody who's an osteopath who is licensed to practice and become a clinician. And increasingly, we have physician's assistants who are clinicians, in the sense of really delivering care. Now, that clinician should really do two things with their time, and if they're a proceduralist like a nurse anesthetist or a midwife, three. They should focus on difficult diagnostic dilemmas. And that's what all those years of training are about. They should focus on a relationship of trust, the healing relationship of trust between a physician or a nurse practitioner or a midwife or a nurse anesthetist and that patient. If they're a proceduralist, right? So a nurse anesthetist or a nurse midwife, then the procedure is helping with birth or delivering anesthesia, which is the third thing. But I can tell you from my experience, and I think that's the experience of most of us now who look at this new model of care, is that many other folks do the role that they should be doing much better than those of us who are trained as clinicians. So a clinical pharmacist probably does a much better job of understanding medication management and the training around medication and medication management than a clinician does. A behavioralist is probably the right person to engage around behavioral issues and that sort of thing. And just like physicians who specialize in greater depth around delivering difficult diagnostic dilemmas around their particular body part, or as I call them, partialists, the nurses as well have a scope of learning that is incredibly broad. When I think about a team of folks that delivers care, now that we're moving towards a team-based model of care, I think of the nurse really as the power piece on my chessboard. Nursing comes out of a background of caring, right? Even the term does. It's quite different than the role of a clinician. And probably in my experience, a nurse who is trained to work as a nurse educator does a heck of a better job around nursing education, around patient education than I would do as a clinician. Learning disabilities, mental health, community health nursing. I mean, the role of the nurse is just incredibly broad. The role of the midwife in many cultures is just an important and powerful role that is played in caring for pregnancy, delivery, and really early childhood. It's just an immensely important role. But really the function again of what a clinician should do is difficult diagnostic dilemmas, relationships, and the procedure that they're specialized in doing. So as we move into this new model of care, as we move into team-based care that's centered on the needs of the patient, a really, really important concept is where in the delivery system is there accountability for the data? If you're going to have multiple people functioning in the model of care for that patient, if you're going to have a team approach to care, then there has to be some place in the delivery system where that data comes together so everybody is singing from the same sheet of music. The concept of that was articulated way back in the 60s by Cal Shia, a pediatrician in Hawaii, the concept of the medical home, and what people confuse that term about is a home for the patient, or a home for the doctor, or a home for the nurse, or a home for the pharmacist. It's none of those things. It's a home for the data. If you're going to have data, where does it reside? Where in the delivery system does it reside? And where it should reside, we think, is wherever that healing trust exists between a clinician and a patient. And anybody else in that relationship should be supporting that relationship of trust with that healer or with that clinician. Very, very important concept. You know, we think of perhaps the medical home as a concept that really is in primary care, because I think most people should have a medical home in primary care. But the first folks who actually acted on that and actually utilized that model of care were the pediatricians with children with special needs. So you have a teacher, you have a clinical psychologist, you have social workers, you have nurses, you have midwives, you have a series of folks who are caring for children with special needs because of the degree of complexity. And Cal began to understand that if you're not singing off the same sheet of music, if there's not a system integrator, if there's not a place where all the data exists and resides, to understand what you need to do with that patient, the patient's not going to do very well. The next place in medicine that this became really understood and important, again, was not in primary care, it was in transplant surgery. So the transplant surgeons, they began to realize very quickly that they needed a team approach, right? They needed a nurse educator. They needed a clinical pharmacist. They needed somebody who understood the immune complex. And if they didn't all sing from the same sheet of music, if they didn't have all the data, their patients died, right? I mean, very sick patients. And so this concept of a place in the delivery system where the data resides, where everybody on that team can work on, known as the medical home, I think is really immensely important in this new role. That brings us to the core concept of what we're now doing in this new world. So what's happening all over the world is we're moving away from delivering an episode of care to understanding how to manage a population with everybody in that population having a plan, right? Just like the concept of the master builder moving to an architect to design, an engineer, and a plan. So in theory, we should really have a core concept of every patient should have a plan. It may be very simple. It may be a plan for wellness checks for an adolescent and making sure that they get their immunizations at the appropriate times. It may be very complex with somebody with 5 organ system disease, right? But nonetheless, a plan for every patient is what we're moving to in this model of care. You know, a story that I want to tell you about here is my taxi driver in Dublin. And I got in a cab at the airport and I was heading into town, and I began chatting with this cabbie, nice guy. And what I learned was that his wife, at the age of 47, had a stroke. 3 kids, a teacher. She's now paralyzed on one side, has difficulty speaking. And that's the failure of a plan, right? That's not monitoring hypertension. That's not understanding that there needs to be a comprehensivist. There needs to be somebody in their life that monitors and interacts with them over the basic things that have to happen. I mean, in the United States and Ireland with a smaller population, that event, that stroke occurs every 3 seconds. mean, that's a huge cost to society for the lack of having a plan. My next story is really about speaking at a medical school a few years ago in Oklahoma. And they redesigned their training to map to this model of team-based care. So when I was a medical student, one of our first classes was Introduction to Clinical Medicine, where we would have 4 medical students and a patient, and we would try to ascertain from that patient their chief complaint, right? What did they come in today for? And the shift in this medical school, which has now occurred in many other medical schools, was that those 4 students were no longer 4 medical students. It was a nursing student, it was a medical student, it was a clinical pharmacist, and it was a behavioralist. And what is that saying? That's saying on day one that this is going to be a team sport, right? We're going to function as a team, and we're going to function to the top of our license. And even though we're training to do different things in different ways, we're going to have to all sing from the same sheet of music eventually. And we're going to have to coordinate around the needs of the patient and not a doctor's brain anymore, right? That's the shift. So what I see happening in many parts of the world is that role of the system integrator, or what's seen here as the patient-centered medical home, is the place that begins to coordinate across the needs of the community. What I saw in Ireland and England was the role of a community care team and a community coordinator. So it wasn't just the sick care needs of the patient. It was the social needs of the patient that were also looked at, because, you know, you're not going to do very well as a diabetic if you don't have a house to live in, right? If you don't have a home, if you don't have a friend that's going to help you, it's going to be really difficult. So being able to pull together that team around that patient is really, and family, by the way, is really, really important. So it's the nurse coordinator, it's the social worker, it's the community health workers, it's the care coordinators. And many of these roles are traditionally coming out of nursing education and not medical education. Really important. But we're really moving towards a coordinated health system with information, with data. So the future we're moving to is really going to be data-driven. And data is going to do for our minds. It's going to make it clear to us what we need to do for this patient, in the same way that in my lifetime, imaging has been clear to our eyes, right? We used to see these scratchy shadows in ultrasound. Now it's like an anatomy textbook, right? We can see clearly what's happening. That process of data is beginning to transfer. So as we move away from the information age into the age of intelligence, thank God, for the first time, there's really hope that we can have the kind of data that every person can actually have a plan. Again, it's not just the people in front of you, it's the people in your population. It's everybody having a plan. And it's going to be team-based. You know, again, I can't emphasize enough how important, how very, very important the whole program of nurse training and the various roles that nurses have taken on as they specialize in their areas of interest: nursing education, nursing mental health, community health nursing. I mean, it's just an immensely important and powerful role that's played in the future of healthcare. And what's going to happen is that we're going to be managing a population down to a plan for every human being. You know, I just can't wait until we have the kind of data and we have the time of team that we can cut in half, or maybe cut in 2/3. The story that I just told you of the 47-year-old teacher who is now paralyzed and having speaking difficulty with 3 kids, right? I mean, what a cost to society not to have had a few cents of antihypertensive medication that could have prevented that if we really had a plan for that patient. I think the other thing that I've seen throughout my journey of 40 years, and I think of my journey really as 3 legs of a stool. It's the cultural shift, and by the way, a huge cultural shift, away from delivering an episode of care with the brain being your data storage device, to a plan for every patient. It's a cultural shift away from the doctor being the center of that universe in this data storage device, to valuing each and every member of the team, and the role and the work that they do. I mean, so important. And again, when I think about what we look at, sort of what's the tip of the iceberg, and not at the whole patient, not at the whole needs. What I find is if we focus only on the sickest few, if we focus only on that acute episode of care, we really miss the enormous opportunity to decrease suffering and cost. When I was in Ireland, I did a radio show, talk show, and I was asked a question about the trolleys in the emergency room. Should we build more hospitals? And my response to that question and to that conversation was, you're asking the wrong question. The right question to ask is how do I change the delivery system? How do I engage a team approach to care so that you don't need more trolleys in the emergency room? When you do the basic, simple things, aspirin, blood pressure, cholesterol, right? Smoking cessation. And when you do that systematically, what we see is 1/3 less need to do heart surgery, right? 1/3 less need to have a bed in the hospital, for somebody who could have had that episode prevented. Over 1/3 less need to have hospital beds for strokes. So, I mean, I think it's really going to be important that the various roles that we have to play. Again, the role of the community health nurse, the role of the nurse educator, the role of that nurse midwife in really interacting with the population around childbirth. I just cannot stress enough how important that is. So there's really 3 drivers of this change in care around the world. This happens to be the United States, where we have seen our life expectancy decline over the past few years, and we spend twice as much per patient than anywhere else in the world with terrible results. And if you look at this, it's very depressing. But the fact of the matter is that we're now spending almost close to 20% of our economy on sick care, and without adopting a model of care in which every member of the team, including the nurse educator, the community health nurse, and the clinical pharmacist and the behavioralist, is really engaged in a more powerful way, it's really important. So this particular chart shows us something that's really interesting. It's the best way to judge whether a healthcare system was, that is, what percent of 40-year-olds are alive 15 years later? Again, we have the worst results at twice the price. The second thing that's really driving this is data. So as I look at those three legs of the stool, the first thing is the cultural shift away from an episodic care towards managing the population. The second is payment change. There's only one way to herd a cat, and that's to move the food. If you put the food only in front of the GP, for example, in Ireland, and that's where the money goes, or only in front of the hospital, only in front of the emergency room, you'll get utilization there. I mean, you need to change how you pay. You need to move away from paying for an episodic care towards paying for those things you really want to have happen, right? And that shift really requires legislation all over the world, including in Ireland. I had the privilege of actually addressing both houses of parliament in Ireland around this issue a few years ago. And hopefully with the pandemic and the understanding of how healthcare needs to change, there'll be a shift to really empower members of the team, including the nurses. And the third thing that's really driving this change is communication and the ability to communicate more effectively. My kids, who are in their 30s now, my two boys, have never seen a teller in a bank. They never will. I mean, they do everything online, right? I happen to be a healthcare ambassador for the nation of Denmark, where I've worked with them for a couple of decades. And what we've done there is move from over 100 hospitals down to 20, speaking of beds and trolleys, by more effectively communicating and engaging and delivering care at home. But, a simple example, I mean, it would be very easy if somebody has a chronic disease. The aluminum foil, when you push it through the pill, it could let you know that the pill was dispensed, and an automated reminder could occur if it wasn't dispensed. But just think of what a nurse educator could do if every time you left the clinician's office, you had an automatic reminder of the 5 things that this clinician just told you should be doing, and then some sort of an automated reminder. But the power of communication is going to fundamentally change how we deliver care. Utilizing services that are beyond the standard services. I had the privilege of looking at and studying a system in the island of Jersey where they took the postman, who goes to every house every day, and began to have them do something called call and check. So, the frail elderly. I was walking around with Joe, the postman here, and this is Millie. At the time, she was 97. And when I asked her what she thought about call and check, a little tear came to her eye, and she said, "I'm so lonely." But here's a service that happens every day in many parts of the world, and I have happened to have had a chance to speak to the folks in Irish Post and saw the amazing history of the main post office in Dublin. But it's just an amazing ability to think about how to utilize all kinds of services to support that patient. So if somebody discharged from the hospital, the postman will call and check on them. They'll notify if somebody is, in this particular case, this lady's daughter lived in London, and just like a notification that express mail was delivered, a notification that her mom was delivered at her permission to her daughter in London. And the next house I visited, the young lady looked quite distraught. And the postman had enough sense, because he visits frequently, to know there was something going on. So let the visiting nurse know that there was a concern. The visiting nurse contacted the patient and asked the patient to come in to do some laboratory tests, sent a car out to pick her up, and discovered that she had been abused by her husband and was in trouble, and managed to get her to safety. But again, thinking about what is available across the system to really begin to deliver care more appropriately. So with that, I would like to thank you all for listening today, and it's a pleasure to be with you. And again, I want to stress, and can't stress enough, the immense importance that the nurse disciplines plays in the delivery of care, and to see the growth of that, to see that basic understanding of what a nurse does well, does better than anybody else, positioned, to be an effective mental health nurse, to be an effective nurse with learning disabilities, to be an effective nurse supporting their patient in the primary care delivery system, to be an effective nurse as a nurse anesthetist or a ward nurse in the hospital. I mean, just such an important role. And again, thank you very much. Bye-bye now.